Hello and welcome to Inside Oncology, a podcast from Cancer Matters, where we explore the most pressing issues in cancer care, research and patient stories. I'm your host, Puvanraj Kanagraj, and today we're diving into two cancers that are especially relevant in this region, nasopharyngeal, NPC, and oral cancer. I'm joined today by two wonderful guests, Dr. Nina Satar, clinical oncologist at Pantai Hospital KL, also known as Dr. Nina, and Dr. Priyanka Mahendru, general dentist and resident dentist from Pantai Hospital KL. Thank you both for being here today.
Thank you, Raj. Thank you.
Dr. Nina and Dr. Priyanka, to start us off, can you each briefly tell us about your roles in tackling NPC and oral? We obviously had this conversation earlier, Dr. Priyanka, right? It's not just one doctor who's tackling just one patient's treatment. It's multidisciplinary. There's this sort of collaboration happening. So what are your roles when a patient, let's say with NPC comes in or oral cancer, how do you both get together and say, there's different layers to treatment to this?
I'll probably take this first. I truly believe that gone are the days one doctor looks after one patient. We really work in an environment where everyone is very subspecialized and they have a different skill set to bring to the table in terms of a journey for a patient. For me, I'm a clinical oncologist. What that means is I am a cancer doctor. I treat patients with a confirmed diagnosis of cancer with either drug treatment, so that can be chemotherapy or targeted therapy, and radiotherapy, that's X-ray treatment. I work closely with Dr. Priyanka, and we usually would discuss our patients together. I'll let Dr. Priyanka introduce herself.
Okay, so I believe that when experts join forces, the patient wins. So I usually step in when I get a call from Dr. Nina, and that is, as she said, when she has a confirmed diagnosis. And my region is the oral cavity, the most, I would say, underlooked part of our body. And so when the diagnosis has been made for a patient, we assess the patient. I assess the oral cavity to kind of provide a dental clearance. Now, what is a dental clearance? We're kind of clearing the patient to start radiation therapy, chemotherapy, or even surgical work that needs to be done. We are basically removing potentially teeth that may not be able to survive the radiation treatment. There are risks and there are side effects that happen when a patient has to undergo radiation, and more often than not, the teeth are the collateral damage. So we try and remove teeth that are not doing too well. Teeth with poor prognosis have to be removed prior to a patient undergoing radiation, and that actually helps to greatly reduce this side effect called osteoradionecrosis. So I step in to clear their oral cavity to make sure that their hygiene is good and any teeth that are not doing well are out before the actual cancer treatment starts.
Would you say your role is exclusive to oral cancer treatment, or if let's say a patient comes in with NPC, you have signs, you're nasopharyngeal, you have confirmed it's nasopharyngeal cancer, you take on radiotherapy or chemotherapy, will this also affect the oral area for NPC, for instance, or will just only people with oral cancer have effects from radiation?
I can take this, Raj. Absolutely. Anyone that who's going to go through radiotherapy treatment of the head and neck, and they would have a delivered dose of radiotherapy to their mandible, would then be at an increased risk of this term radionecrosis, or where the bone of the jaw dies, right? And the repair process afterwards becomes inefficient. So yes, for patients who have nasopharyngeal cancer that's going through radiotherapy, they would need to see Dr. Priyanka first. And the uniqueness of this relationship that we have is that we discuss our patient and treatment plan together. It's important for Dr. Priyanka to know where my high dose region is going to be, so that she can take extra care to those regions when she's doing the dental clearance. So perhaps this discussion is really the most important bit of looking after patients.
But when we are speaking of nasopharyngeal and oral cancer, obviously the terms of radiotherapy, chemotherapy, treatment may differ. How would patient know? How, if patient says, I've got naso, will it be in a specific area? Is there difference between treatments for both cancers? Would they just target it into one side of the face? These are questions that patients would tend to have, right? And how, if as a patient, if let's say there's a patient comes in and says, how would I know if it's nasal, if it's oral, if everything's in my face, right? How would you start explaining this to the patient?
Absolutely. I think we're becoming very technical here. I just want to remind ourselves that oral cavity cancer is a completely different entity than nasopharyngeal cancer. For oral cavity cancer, the main person that needs to remove the cancer would be a surgeon, right? Radiation treatment would usually be adjuvant. That is a fancy word for post-op or after the operation. So usually once the surgeon removes the cancer and then there's high-risk features, then I would say yes, there's treatment of radiotherapy is indicated. Then I would discuss with Dr. Priyanka and say, I'm going to give high dose to the left side because that's where the tumor bed is and the cancer has spread to the left lymph node of the neck, and that's where my radiation therapy would be. And then I would explain that to Dr. Priyanka so that then when she's doing her assessment, then she would be reviewing that more carefully.
I think if I may add, oral cancer is a type of head and neck cancer, and it's in that region. And although both are different, they are similar in certain aspects. And in terms of both of these cancers sharing symptoms, yes, there are some overlapping symptoms. But in terms of the actual location, because nasopharyngeal is more at the back of the nose and at back of the throat, that region, whereas oral cancer sits pretty much anywhere in the oral cavity. So most times, for example, it can be at the tongue, gums, it can be inner lining of the cheek, floor of the mouth, palate. So surgical intervention is more often than not required. So that does come hand in hand with some sort of radiation therapy for the targeted cells and sometimes chemotherapy. So I think that once the symptoms are caught, and that's when we're moving to the actual diagnosis and we're able to branch out which head and neck cancer.
Are there similarities in symptoms between both these cancers that patients may get confused about?
Yes, I think both both can present with lumps around the neck. They can present with even sores and ulcers in the mouth. Patients can have difficulty swallowing, eating, chewing, like a persistent or throbbing pain. In the ear can be in the oral cavity as well. So I think these are some of the shared symptoms.
So at what point, if patients has these symptoms, they come in to see either one of you, they come to see you first, Dr. Nina, what are the sort of tests that you'll have to actually carry out to actually identify, to either rule out oral and decide it's naso, or to rule out nasopharyngeal and then decide it's oral cancer? What are some of the tests that you can take us through?
Okay, so usually those tests are being done by ENT surgeons or oral max fac surgeons, and not myself. I pretty much sit more at the back end once the diagnosis is made. But usually if you go to see them in clinic, they would be assessing those areas. So as an example, to assess the nasopharynx, which is the part right behind your nose above your throat, they would need to do a nasoendoscope, which is really a flexible scope with a camera at the back, and it's very, very thinner than your pen. It goes right behind your nose to then really review the area behind, which is the nasopharynx, with a camera so that you can also look at that. So that's usually, and if there is growth there, they would take a biopsy from there. That would usually be for nasopharyngeal cancer. But for oral cavity cancer, they could present straight to Dr. Priyanka in clinic.
So I think the history taking, for me, asking about family history, or whatever that they're presenting with, those questions are of very high importance. We have to, let's say a patient is just presenting an ulcer, and we want to know the history of the ulcer, the timeline of that ulcer, and if the ulcer is looking suspicious, from that history we're kind of able to gauge, and that's when we do get an oral max spec or an ENT surgeon on board to then biopsy.
But we get ulcers time to time. More often than not, maybe in a month, you tend to get those. People, with Asians, it's always the heat, the weather is hot, so that's why you get ulcers. You're not drinking enough water, so you get ulcer. The body is heaty, you get ulcer. Should we be concerned? Or do we wait for a while and say, do we wait for a week to see if the ulcer doesn't reduce or it doesn't get better? Is that when we go and see a consultant or whatsoever? Is it something to be concerned about, and how long should we wait before things like ulcer? It's such a common thing in our day-to-day life.
So to answer you, not all ulcers are cancer, right? They could be a frictional ulcer, a stress-related ulcer, a heaty body ulcer. There's no such thing though. An aphthous ulcer. But it's when you notice an ulcer or a lump or a bump in your mouth that is persistent for 2 to 3 weeks, and you've applied everything off the shelf. You've applied your Bonjela, your Aftermed, your any possible ulcer gel in the market, and the bug is not going away. You're noticing a foul smell. That's already a red flag. And a lot of the times patient has ignored that. So I would say if it's persistent, 2 to 3 weeks, it's not budging, it warrants you to get a full oral health examination done.
Let's talk about risk, right? Family history plays a very important factor when it comes to getting people to go for screening. But in the case of NPC and oral cancer, where does this play as a factor? Are there screening tests available for NPC, for example, and are there screening tests available for oral cancer? So maybe we'll start with NPC first. An individual with family history, how much should they be concerned, and are there screening tests available?
Sure. So for NPC, the risk really is higher in Southeast Asian population. We really own this disease called NPC compared to the whole world. We have one of the highest risk of developing NPC here in Malaysia. And if you look at Malaysia data, in the National Cancer Registry 2021 data, NPC is top 6 cancer amongst the male, right, population. And then if you look at Sabah Sarawak, in Bidayuh descent, they have the highest incidence of NPC in the world, right? So surely if you are of Bidayuh descent, you're male, you're above 30, and you have a family history, then that's really a factor for you to get checked up, especially if you have symptoms. If not, at least then go and see your ENT specialist to discuss options. We don't have screening available in Malaysia for NPC yet, but there are lots of research going on, especially to detect EBV blood test, right, to see whether there is. So it's a simple tool, for example, EBV blood test together with a nasal endoscope in someone who was high risk population. So honestly, the message across is, what is your risk for this? If you have a family history, that increases your risk already. In the Chinese population, 1 in 100 males get NPC compared to the Indian population, 1 in 1,000. So Chinese has higher risk compared to the Indian in getting NPC. So, but more so importantly, I want to impress upon is that if you have symptoms, for example, especially in NPC, it's neck swelling, then that doesn't go away after 3 weeks, not associated with fever, things like that, then you do need to go and get yourself checked out.
Now, what about oral cancer, Dr. Priyanka?
I think for oral cancer, especially if you have a family history of a cancer in the head and neck region, then you are at a slightly higher risk because of the inherited genetic mutation. But for oral cancer specifically, use of tobacco, lifestyle, diet, alcohol, use of vape, all these are contributing factors. So, and as what Dr. Nina said, even for NPC, it is more male predominant. It is pretty much similar for oral cancer.
I see. When you mentioned lifestyle and habits like vaping, for example, smoking and drinking, obviously, there are statistics to show that consumption of alcohol is going down among younger people, but that may not be the case with vaping. How does vaping, or someone who vapes, for example, on a day-to-day basis, will the chances of them contracting oral cancer be higher, even if they don't have family history, for example? And does this apply to smoking as well? Do they both have very similar statistics, and can you get oral cancer if you're, let's say, less than 30 years old if you vape every day?
So honestly, because vaping is fairly new compared to smoking, the data and research with regards to smoking increasing the risk of oral cavity cancer is there. So that we know. So if you and you ask me, so if you're below 30 and you're you're smoking every day, absolutely. So if you start early, since 10, and we do know there are a lot of parts of Malaysia where young schoolboys are starting smoking at that age, by 20, that's 10 years of, if they smoke heavily, damage is already done. So I have seen someone who's 22 with oral cavity cancer, for sure, right? And so yes, it can happen. It's just the timeline. So the earlier you start, the earlier you can get the cancer. That's with regards to smoking. With regards to vaping, the data isn't matured yet, but because the chemicals inside vaping can have harmful effects, then we believe it could contribute to increased risk of oral cavity cancer.
As someone who looks at mouths daily, and one of the first few questions I ask my patients, like, do you smoke? And they respond, I don't smoke, but I vape. Because,
like it's something that's
like it's, if given a choice, I'd rather vape than smoke. But as what Dr. Nina said, there actually isn't enough research to show and to, say the damage that it is causing. But definitely some damage is being done.
There are very visible symptoms that, when someone vapes and then they start to see that their mouth feels sore, there's ulcers. Has there been a change in symptoms as people vape more, smoke more?
I mean, for sure, because the liquid in the vape, there is nicotine. I'm assuming the tar has been removed, but the way the newer vapes are, I think there's a lighting agent or there's a electric component to it. There is a reaction that is happening in the oral cavity. The mucosa, the inner lining of our mouth, is very sensitive to this. So can I say for sure that a patient who vapes versus a patient who smokes will have more or different changes? I think I can safely say, and what I've seen is we do see intraoral changes for patients who are smoking and vaping, whether it's changes around the mucosa, gums, but teeth as well. And any of these changes are enough they pose a risk of altering the cells in the oral cavity, and which may lead to an oral cancer. And patients are at a higher risk with smoking and vaping of developing sores and ulcers that are going to be persistent for a longer period of time. And it's not just sores and ulcers. We're talking about red and white patches. It's changes on the tongue. It's around the mucosa, palate, smoke burns. These are all changing greatly and altering the cells in the oral cavity, and that cell proliferation may lead to.
All right. I'm quite keen to explore HPV, but before we go there, I think, and this is a question that just popped into my mind, right? Cancer spreads. Can NPC or nasopharyngeal cancer and oral cancer actually spread to other parts of your body, even beyond your head, beyond your neck, left untreated, or ignoring these symptoms that you have mentioned, can it worsen to actually affect other parts of your body if you really don't take early precautionary steps?
Absolutely. So our body is interconnected. One organ is connected to another organ. How? Through blood vessels and lymphatic supplies. So we have lymphatic supplies via our lymph nodes, lymph glands, that supplies parts of our body behind the nose, nasopharynx, as well as oral cavity. And that's how the cancer cell can migrate and travel. And most of the time we see them migrate to the lymph node in the neck, and then from the lymph gland they can go to other lymph node in the body. Via blood it can go into some other parts of your body. So there's this thing called seed and soil hypothesis, where the cancer cell goes around in the blood vessel and it looks for organs that it can flourish in. So for nasopharyngeal cancer, that's usually the lung. It can be the liver or the bone as well. So yes, if left untreated for some time, it can travel and spread. So from early stage 1, it can get to stage 4.
But does daily habits such as vaping, for example, we were speaking of vaping earlier, can they accelerate the spread of this cancer to the lungs, for example, when you mentioned nasopharyngeal cancer?
I wish we have data and enough research.
What about smoking then? Can that accelerate the spread of this cancer?
So in terms, what it can do is that it can cause issues when you're going through treatment. So for my patients who are going through radiotherapy, for example, the side effects of radiotherapy are much worse when and if my patient is smoking. On top of that, their lungs are already affected by the smoking, so they don't have the same capacity as a non-smoker.
Okay. We've also read that HPV, the human papillomavirus, is related to oral cancer, right? Dr. Priyanka, are they linked, and how are they linked if they are linked?
So HPV is a common virus that is transmitted through skin-to-skin contact, including sexual contact. And one of the strains, HPV-16, it actually can infect the oral cavity, the mouth, the throat. And this causes changes to the cells in the oral cavity, and then, of course, you're at a higher risk of it leading to an oropharyngeal cancer. In fact, it is currently one of the leading causes for younger patients developing an oral cancer. And these are patients, the class of patients that are not tobacco users.
Right. The very conversation about HPV, for example, we were talking about how NPC and oral dominates the male population, but for men, the very when we speak about HPV, they say it's a female-oriented virus, right? It's not going to affect me. But I can only assume, are those myths, or can men too contract HPV, which could also lead to oral cancer as well?
So HPV increases the risk of oropharyngeal cancer. So oropharyngeal cancer is oropharynx that sits behind the oral cavity. So oral cavity is the front part. When you swallow your throat, that's considered the oropharynx. And HPV can increase the risk there. So it does not discriminate between genders. So if you're a man or woman and you have the HPV, you can get oropharyngeal cancer from that. I guess the misconception from the general public is because they hear about HPV and cervical cancer, your cervix getting changes because of HPV, and so they think it's a female only virus, but it doesn't discriminate in that way.
What can we do to protect ourselves from potential cases of HPV leading to oral cancer? There's vaccines, obviously, but can we explore lifestyle precautions? What ways can we protect ourselves in that sense?
Practicing safe sexual habits, but also regular oral health or dental screenings I think to me that is the key. Of course, as you mentioned, vaccination, ideally before you become sexually active, but even adults benefit from it too. But safe sexual practice plus regular dental screenings really helps.
Just on that, I just want to touch that vaccination is really key, and not just for our girls, but also for our boys, before they become sexually active. So I think perhaps a lot of your listeners might be young moms or moms, and they're looking after the kids, really to take this message home that you can do something for your kids to protect them from this cancer.
Well, thank you, Dr. Nina and Dr. Priyanka. We are towards the end. But before I wrap up, I'd like to ask each one of you for a key takeaway. It could be related to NPC or to oral cancer. What would you like patients to really know about these cancers? What is the one key takeaway message you think they should actually take home from listening to you speak today?
Early diagnosis saves lives. So really increase your awareness and go and see your specialist for early checkup if there are any changes, because if you can catch it at an early stage, we can cure you from your cancer.
Yeah, I mean, both oral cancer and NPC are very silent in their early stages. So yes, early detection saves lives. Regular oral checks, as much as you hate going to your dentist, go to your dentist every 6 months. Do those regular dental screenings, get your medical checks done, be aware of symptoms. Don't take symptoms of lumps and bumps in your mouth lightly, especially if they're not looking like the normal regular ulcers. Know about your family history and take action. And as I mentioned earlier, that when experts join forces, patients win. So these are cancers that require a multidisciplinary team, and patients are I would consider them fortunate if they're able to get a good multidisciplinary team. So yes, early detection saves lives, and we have to be aware of all symptoms that are occurring in our mouth.
Thank you, Dr. Priyanka. Thank you, Dr. Nina, for sharing your insights today, and thank you to our listeners for joining us in Inside Oncology. And if you found today's discussion helpful, do share with your family and friends. Until next time, I'm Puvanraj Kanagraj, and I'm your host from Inside Oncology. Stay safe, stay informed, and stay healthy.